Hello and welcome to Insight of Ophthalmology. This is Dr. Amrit welcoming you to another lecture. Today we are studying the anatomy of lens. Before we understand the anatomy of lens, I would advise you to study the development of the lens vesicle, which I have explained to you in this video on development of eye. Now, what is lens? Lens is basically a transparent, biconvex, crystalline mass which is placed in between the iris and the vitreous body. Now, the lens is basically situated in a saucer-shaped depression at the anterior face of the vitreous, which is called the patellar fossa. So, the lens nicely sits in that patellar fossa. So if this is the vitreous anteriorly forms this cavity in which our lens will nicely sit, and that is called the patellar fossa. And of course, in front we have the iris. This is the correct time to discuss the important ligaments which are associated with the lens. The lens, as we know, is nicely sitting in the patellar fossa, and in a circular region of the patellar fossa, the lens has a strong adhesion because of the presence of a circular ligament around it, which is called the Wiegert's ligament or the hyaloid-capsular ligament. It's called hyaloid-capsular because it's present between the hyaloid, that is nothing but the vitreous, and the lens capsule. Now, the lens is not firmly adhered throughout the patellar fossa. So there is still a part behind the lens which is loosely attached to the hyaloid face where we have a space, and this space is called retrolental space because it is present behind the lens, and it is also called the Bergers space. So let me explain it to you. So you basically have your patellar fossa, which is represented here in the gray color. The lens is nicely sitting in the patellar fossa. Now, along a circular margin where the wiegert ligament is present, the lens is firmly attached, and in between that wiegert ligament, the lens is loosely present in a space. So there's a space where the wiegert ligament is not attached, and that space is called the Berger's space. So what are the functions of the lens? Lens basically helps in transmitting and refracting the light. It also absorbs the ultraviolet light, which is of less than 350 nanometers wavelength. So in a way, our lens is basically preventing us from the damaging effect of the UV radiation, and it prevents those UV radiation to reach the retina. It contributes to 35% of the refractive power of the eye. Another important refractive surface of the eye is our cornea, which gives the majority of the refractive power, and the second most important surface is our crystalline lens. Another thing is it helps in accommodation. Okay, now let us talk about some important measurements of our lens. We know that the lens has an anterior surface and then it has a posterior surface. These two surfaces are going to meet at the equator. Okay, so wherever they meet, that is called the equator. Now, as you can see in this diagram, the anterior surface is much less curved compared to the posterior surface, right? And therefore, the radius of curvature of the anterior surface is much more compared to the radius of curvature of the posterior surface. Okay, so you must not get confused here. The more curved a surface is, the lesser is the radius of curvature, right? So the radius of curvature of the anterior surface is about 10 mm, and that of the posterior more curved surface is about 6 mm. What about the equatorial diameter, which is drawn here in green color? The equatorial diameter, that means if you draw a line from one equator to the other, the equatorial diameter of the lens at the time of birth is about 6.5 millimeters. And as you reach the second decade of life, which is about 20 years, 20 to 30 years, okay, at that time the equatorial diameter will become 9 to 10 millimeters, okay, and then it stays constant. So the adult diameter or at the equator of the lens, if someone asks you, the answer is 9 to 10 millimeters. Now what about the lens thickness? The thickness of the lens represented here by the blue line is basically a line drawn from the anterior pole to the posterior pole of the lens. So in a while I'll tell you what is meant by the anterior pole and the posterior pole. So lens thickness is about 3.5 millimeters at the time of birth, and then it reaches maximum to about 5.5 millimeter. It increases by a unit of 0.2 millimeters every year. Now, the center of the anterior surface of the lens and the center of the posterior surface of the lens is called the anterior pole and the posterior pole respectively. Now, the anterior pole is situated about 3 millimeters from the center of the cornea. So, that's also a very important point. Now let us talk about the refractive properties of the lens. The refractive index of the lens that we should remember is about 1.39, and the refractive power of the lens is about 16 to 17 diopters. Now the refractive power is definitely different from accommodative power. The refractive power is basically the ability of the lens to bend the light rays, and the accommodative power is the power of the lens which helps you in accommodation. That means which helps you to look at closer objects, right? This accommodative power is maximum at the time of birth. It is about 14 to 16 diopters at the time of birth, and then at the age of 25 it becomes 7 to 8 diopters, and then at the age of 50 and then old age sometimes it even becomes 0, right? So the accommodative power basically decreases gradually, and this is actually associated with the refractive condition that we see in old age and usually after 40 years of age. Do you know what it is? It is called presbyopia. So if you want to know more about accommodation, we have a video on what is accommodation and what is the accommodative power of the eye. Now let us discuss our topic, that is the anatomy of the lens. We shall be discussing the anatomy of the lens under the headings of lens capsule, lens epithelium, and the lens fibers. First, you should understand how the lens develops, right? This was explained in detail in development of eye. Still, to summarize, the optic vesicle is in close contact with the surface ectoderm. So this is the surface ectoderm. A part of the surface ectoderm which is in close contact with the optic vesicle will undergo thickening and will form the lens placard. Okay. Now gradually what happens is this lens placard is going to start invaginating inside this optic vesicle, converting the optic vesicle into optic cup, and subsequently this is going to get separated and form this circular structure surrounded by the epithelium of the surface ectoderm all throughout, and this is called the lens vesicle. And of course your optic vesicle is converted into the optic cup. So this is what was explained in that video on development of eye. So now let us talk about the lens capsule. If you would remember this diagram, this is nothing but this is your lens vesicle, right? So this lens vesicle is actually surrounded all throughout by the lens epithelium, okay? So which was derived from the surface ectoderm. Now the basal cells, that means the outermost wall of these epithelial cells, is actually going to secrete a membrane-like structure around it, and that is called the lens capsule, right? So lens capsule is a thin, transparent, hyaline, collagenous membrane which is surrounding the lens. Now, although it does not contain any elastic fibers, it is highly elastic. That's important. It is produced throughout the life. So that is also one more important point. And if you see, it is produced by the basal portion. That means this one, the outer part, is called the basal portion. So it is secreted by the basal portion of the epithelium anteriorly, and the basal portion of the posterior lens fibers posteriorly, not the posterior epithelium. So why the posterior, not the posterior epithelium? I'll tell you in a while. Before that, did you know that the thickest basement membrane in a human body is nothing but it is the lens capsule? Okay, now the lens capsule stains with periodic acid skiff stain. So that also one more point that you should remember. Coming to the thickness of the lens capsule, this has clinical importance as well. The thickness of the lens capsule is not equal throughout. The lens is thicker anteriorly compared to the posteriorly, and it is thicker at the equator compared to the poles. And as a matter of fact, it is thinnest at the posterior pole. So that brings us to a clinical nugget, and that is number one. in true exfoliation of the lens, okay, that is seen in case of glass blowers disease, okay, and people who are actually glass blowers or those who work at high temperature. What happens is that the anterior superficial lamella of the lens capsule, so basically the lens capsule gets separated into two individual lamellae, right? One will be superficial and one will be deeper, right? And that you can see in this diagram. So it looks as if the anterior capsule has actually split off into different layers because of that heat, right? So that is called true exfoliation syndrome. Now here you can see this is actually a histological slide in which the capsule has been stained with the past stain, and you can actually see how the capsule has been, broken into individual layers, okay. So this is seen in the true exfoliation syndrome. Now one more clinical nugget related to the thickness of the lenses. What did I tell you? The thickness of the lens is least in the posterior pole, and therefore at the time of surgery, the most common place where the lens capsule gives away and the most common complication as well that you see is the posterior capsular rupture, right? So this can happen with some instrument touch, sometimes during hydrodissection due to the inherent weakness of the posterior capsule. So this is called posterior capsular rupture, which is a complication of the cataract surgery. And why it happens? Because the posterior capsule is weakest at the posterior pole. Now let us discuss about the lens epithelium. Here, do you remember that I told you that the posterior capsule is formed from the posterior lens fibers and not from the posterior epithelium. Why? Because we do not have a posterior epithelium. So, if you would remember, this is the lens vesicle, right? At this point, the lens vesicle seems to have epithelium both at the anterior surface and at the posterior surface as well. However, what happens is that the posterior epithelial cells will now start elongating, and as they elongate, they will fill up this lens vesicle cavity. And now this posterior epithelial cells have elongated and completely filled up this cavity to form what is called an embryonic nucleus or an embryonic lens. And therefore, we do not have a posterior epithelium left after the embryonic period because the posterior epithelium of the lens has been totally used up to form the primary lens fibers during the embryonic period, that is up to 3 months of gestation. So this is very important. So what is primary lens fibers? Primary lens fibers are the fibers which are formed by the elongation of the posterior epithelium of the lens vesicle, right? And they are formed in the embryonic period, that is about 0 to 3 months. Now, because we don't have any posterior lens epithelium, we will be discussing only about the anterior lens epithelium. The anterior lens epithelium are basically cuboidal nucleated epithelial cells. So they are cuboidal nucleated epithelial cells, and moreover they are the most metabolically active part of the lens. They contain all the organelles. So all the metabolism, even the ATP production, it all happens at the anterior lens epithelium. If someone asks you that in the lens which part is utilizing the most amount of oxygen, it is again the most metabolically active part, that is the anterior lens epithelium. Right now, the entire lens epithelium does not divide, right? It's only the lens epithelium cells which are present near the equator which have this capability of division. So based on that, there are zones in epithelium as well. We have some central zone of cells which are labeled in pink. Then the periphery to the central zone, we have the peripheral zone which are labeled in blue. And then we have a germinative zone which is labeled in green. And because the germinative zone is present near the equator, they also call the equatorial zone. So first let us talk about the central zone. The central zone, as I told you and as you can see over here, they are basically cuboidal in shape, okay, and their number also decreases with age, just like the corneal endothelium. Now these cells are usually stable. They do not undergo mitosis normally, okay. So this is the point. However, they can show mitosis in some pathological condition. In some pathological condition, these cuboidal cells will undergo metaplasia and lead to the development of cataract. So this is your clinical nugget here. Example, in shield cataract in atopic dermatitis, and another thing is the glaucoma flecken that you see in the acute angle closure glaucoma, right? In both these cases, what is happening is there is metaplasia of cuboidal cells into myofibroblasts, right? So because of any pathological condition, these anterior capsule, the anterior epithelial cells can undergo necrosis like in the glaucoma flecken, and some amount of metaplasia which is seen in shield cataract and glaucoma flecken both, and it can lead to development of such pathological conditions. Okay. Next, coming to the intermediate zone or the peripheral zone. This intermediate zone cells are much smaller, however they are more cylindrical. They are located peripheral to the central zone and they rarely undergo any sort of mitosis. Finally, we have these cells which are located at the equator, which are also called the germinative zone. So some say they're located at the equator, some say they're located just anterior to the equator, which is called the pre-equatorial zone. But what is important here is that they can undergo active division. Okay, so they undergo mitosis. Now, this is also a zone which is going to form your lens fibers. And since these lens fibers are formed after the embryonic period and they're not formed from the posterior epithelium, instead formed from a part of the anterior epithelium, these are called secondary lens fibers. Okay. So this equatorial zone or the germinative zone are going to lay down these fibers, okay, and these fibers are going to migrate from here posteriorly and then towards inside, right? And these cells actually will continue to divide throughout your life. So that's important. Similarly, here there's another concept of bow region. So what is meant by this bow region? We know that the newly laid lens fibers are laid from the germinative zone or the equatorial zone. And these lens fibers, after they are laid, they're going to start getting elongated. Now, as they start getting elongated, their nuclei will now become more anterior compared to their original nuclei, compared to the cells which are present in the equatorial zone. You can see the superficial cells have zone here and the deeper cells actually have their nucleus present like this, right? So the deeper cells will have their nuclei situated more anteriorly compared to the superficial cells. As this happens, they take a configuration of a bow and therefore this is called a bow region. Now here is an important clinical nugget. I told you that actively dividing cells are present in the germinative zone or the equatorial zone, and therefore as we know that wherever you have actively dividing cells, they are very susceptible to irradiation, and therefore in case of radiation cataract, sometimes even in neurofibromatosis and myotonic dystrophy, you will see dysplasia of these cells and they will not form the normal lens fibers. Instead, they are going to form some dysplastic cells and this will lead to formation of a cataract just below the posterior capsule. Okay, and therefore such a cataract is called a posterior subcapsular cataract. As you can see in the first picture, this is a retroillumination in which you can see this cataract. Okay, this has a nice shape to it and you can see this. Okay, this is called a posterior subcapsular cataract. Similarly, here on the optical section, this is the anterior lens capsule, then you might have the lens, and in the posterior part of that you can see that there is this opacification. That means your posterior capsule, the posterior subcapsular area is getting affected. So this is a posterior subcapsular cataract again. Another clinical nugget here is that sometimes after cataract surgery, what happens is, even though we remove the anterior capsule, we do leave a rim of the anterior capsule after cataract surgery. And that rim of the anterior capsule still harbors some of the germinative cells, right? So these epithelial cells from the germinative zone can actually migrate towards the posterior capsule behind the intraocular lens and they can cause what is called posterior capsular opacification. Right? So these cells basically can form two types of posterior capsular opacification which are called PCO. Okay, so these two types can be L-Schnick pearls or it could be Sommerings rings. Now how does each happen is that the residual epithelial cells, if they migrate posteriorly and they get differentiated into some balloon-like cells or wing-like cells, also called the Weddell cells. These Weddell cells are also seen in your bladder. Okay, so if they differentiate into such cells, they will look like these pearls on the posterior capsule behind the IOL, and these are called the L-Schnick pearl. So each pearl is actually a failed epithelial cell which was supposed to become a lens fiber. Okay, so that is your L-Schnick pearl. Now sometimes they are going to take a shape of a ring, okay, or a donut shaped ring. So that is called a Sommer's ring. So both of these are basically posterior capsular opacification. So I hope that is clear. Now, if you want to know more about the slit lamp examination of a lens and the optical section of the lens, I would advise you to visit this video on slit lamp techniques, diffuse versus focal. The third part in which we'll study the anatomy is the lens fibers. So we discussed about the capsule, we discussed about the epithelium. Now we're discussing about the fibers of the lens. The lens fibers are actually arranged in a zonal arrangement, okay, in zones. So based on that zones, roughly we have a nucleus and we have cortex. However, the nucleus is also divided into further zones, let me tell you. Now, here the concept of primary lens fibers and secondary lens fibers is very important. So what are these primary lens fibers? Primary lens fibers are the fibers which develop before 3 months of age from the posterior epithelium, whereas the secondary lens fibers are the fibers which are developing from the equatorial zone or the germinative zone. So these are your primary lens fibers and these are your secondary lens fibers. The primary lens fibers are basically going to form the embryonic nucleus and the secondary lens fibers are going to form a lot of layers, okay, and each of these layers are actually given different names, okay, based on when they develop. So here the basic idea that you should get is the oldest nucleus or the oldest cells are going to be present in the center, right? And the new cells are laid from the superficial area, right? From the periphery. And therefore, all the new cells will be present in the periphery and the youngest one will be present in the most periphery. The oldest one will be present in the center. The fibers of the lens are basically split into regions depending upon the age of the origin. So as I told you, the embryonic lens is formed at 3 months of the embryonic life from the posterior epithelium and forming the embryonic nucleus, right? So those are the primary lens fibers. Now whatever is formed afterwards is called a secondary lens fiber. Okay, so the embryonic nucleus is a primary and then we have the secondary. Now the part of the secondary lens fibers which are formed during the fetal life, that is 3 to 8 months of fetal life, is called the fetal nucleus. Okay, and obviously the embryonic nucleus will be in the center and fetal nucleus will be around the embryonic nucleus. Then next what we have is the infantile nucleus. From the last month of the intrauterine life, which is probably from the 9th month, up till the puberty, what we get is the infantile nucleus. Then after the puberty, till after the puberty, that is like early adult life, whatever you get from there on is called the adult nucleus, right? And then the most youngest fibers which are present in the most periphery, they are called the cortex, right? So here, let us try to label that. Suppose this is the structure of a lens in a 40 years old, right? So let us label it. So the most outside one, which is labeled as 1, is the anterior capsule, right? Now, just below that will be your actually epithelium and then you will have the cortex, right? Now here, the cortex is labeled in the pink color. Just inside the cortex, we will have the adult nucleus. Just inside that, we will have the infantile nucleus. Then we have the fetal nucleus, and then the most innermost part is called the embryonic nucleus. So I hope that is clear. So here you can see the anterior aspect and the lateral aspect of a cut open lens, right? So you can see the centermost part is the embryonic nucleus. Surrounding that is the fetal. Then we have the infantile, then adult, and surrounding that we have cortex, then we have the epithelium, and then the epithelium secretes what is called the capsule. Now you should know that after the embryonic nucleus is actually secreted, then we have the fetal nucleus coming up. So the initial fibers which are formed surrounding that embryonic nucleus are actually arranged in such a way that as they actually reach together, so they're going to grow from one end to the another, they're going to grow from one end to another. As they reach each other, these fibers are going to now start getting flattened up at their ends, and as they flatten up at the ends, they're going to meet at forming a suture. That suture is called a Y suture. So they're going to terminate in that Y area, right? So anteriorly you have an upright Y. That is a normal way how you write a Y. So anteriorly you will have an upright Y suture, and posteriorly it is actually an inverted Y. Okay, so if you flip this Y upside down, it's called an inverted or a posterior Y suture. So what is the clinical significance of these Y suture? So anteriorly, as you can see, it's a normal erect, okay, upright Y suture, and posterior you're going to have this posterior Y suture. These are nothing but basically the fetal nucleus fibers which are coming, and as they are meeting, they're going to flatten up and they're going to join with each other on the either side, forming this sutures, right? Suture is nothing but it's a junction, right? And what is joining here? It is the lens fibers which are joining in the shape of Y. The importance here is sometimes you can get this cataracts, which is called sutural cataract. So around the suture you will have this opacification of the lens, and this is called a sutural cataract. Next, we shall be discussing about the suspensory ligaments or the zonules of Zinn. So what is meant by the zonules of Zinn? Now, lens is basically held in its place. Okay, the lens is not just free floating. Obviously, it's sitting in the patellar fossa, it has its weigert ligament, but still it needs to have some support and some connection from the ciliary body and from the ciliary processes basically, and especially for the purpose of accommodation. So the lens is connected to the ciliary body via these strands, okay, which are actually going to join together and form lamellae, and these strands are called the zonules, okay, or the zonular lamellae. So what did I tell you? The lens is situated basically between the iris, and it is situated between the vitreous behind. Okay. So now, as you can see here, we have the ciliary body. The ciliary body basically has two parts. It has a convoluted part which is called the pars plicata, and then it has a flatter part which is called the pars plana, right? So between the ciliary body and between the lens, you're going to have what is called the zonular fibers. The zonular fibers, most of them are going to come from your pars plana, and behind the pars plana, what do you have? You have retina, and the anterior part of the retina is called the ora serrata, right? So now in the recent study, it has shown that most of these zonules are actually arising from the pars plana and the ora serrata. So they're going to arise like this and now getting inserted at the equator of the lens. Okay, so they're going to arise like this and insert at the equator, arise and insert at the equator. So that is how your zonules are present. They are present between the ciliary body and the equator of the lens. So that's important. So as I told you that the recent concept is that the zonules are basically arising, most of them from the pars plana and also up to 1.5 millimeters from the ora serrata, right? And the zonules is not just a single zonule, it's basically a complex. And that complex has been divided into four parts. So we have a pars orbicularis, a zonular plexus, a zonular fork, and a zonular limb. So let me tell you what are all these four parts. So first of all, just look at the first picture. The part of the zonules which are coming from the pars plana, okay, the plain part of the ciliary body and the ora serrata, that is part of the retina. The parts which is coming from the pars plana is called the pars orbicularis, right? And these part of the zonules which have arisen from the pars orbicularis, now they are going to reach the pars plicata part. Now since the plicata part is more complex part, you can remember, so the zonules also are going to be more complex there. They're going to be more interlacing. So they're going to form a plexus, and therefore this part is called the zonular plexus part, right? Now, as they have formed a plexus or a base at the pars plicata, now they're ready to divide. Now, before they divide, they need to consolidate and form this angulation, and this is called the zonular fork. Okay, so this trident thing that you can see, those are the zonular limbs, and where they meet is called the zonular fork. Now, from that zonular fork, you're going to get these three limbs outside, which is one is the anterior limb, one is the posterior limb, and one is the equatorial zonular limb. So this is also very important. The zonular limbs, when you talk about, first we talk about the anterior zonular limb. The anterior zonular limb is consisting of the zonule fibers which are coming from the pars plana, that is posterior part, and they are inserting onto the pre-equatorial part of the lens. That means they are going and inserting anterior to the part of the lens. Okay. The posterior zonular limb means that they are inserted on the posterior part of the lens, posterior to the equator, but they are arising from where? They are arising anteriorly, not from the pars plana, that is from the pars plicata. And the equatorial zonular limb is directly arising from the pars plicata and getting inserted onto the lens equator. So I hope that is clear, right? So we have a pars orbicularis, then we have a zonular plexus, okay, then we have a fork, and that fork is dividing basically into the limbs. So that is important. Now here I would like to mention, just for the sake of completion, two important canals which are associated with the zonular fibers. So we have a canal of Hanover and a canal of Petit. The canal of Hanover, as you can see, it's a space between the pre-equatorial and the post-equatorial zonules. Okay, so if this was the pre-equatorial and the post-equatorial, that is called the canal of Hanover. The canal of Petit is a small space behind the post-equatorial zonules and the hyaloid zonules. So basically, hyaloid zonule is nothing but some zonules will be in close association with the vitreous, so that those are called the hyaloid zonules. So if you find a small space between those hyaloid zonules and the post-equator zonules, that is called the canal of Petit. Now this diagram actually explains to you about the three types of zonular limbs that we saw. Okay, so what did I tell you about the anterior zonular limb? The anterior zonular limb means that it is inserted anterior to the equator and it is inserted 1.5 millimeters anterior to the equator. But where are they coming from? They are coming from the pars plana. They are coming from behind, right? And getting inserted anteriorly. Now the posterior limb is actually getting inserted posterior to the equator. How much posterior? 1.25 millimeters posterior to the equator. But where are they coming from? They're coming from anterior part. That means from the pars plicatum. And then of course you have an equatorial limb which is directly coming from the pars plicatum and getting inserted at the equator. So you can see and appreciate this crisscrossing of the zonular fibers. Finally, we have the surgical anatomy of the lens. Now, some surgery textbooks, and for the purpose of cataract surgery, the lens is divided again into a central hard nucleus, okay, and then above that you have a variable thickness of epinuclear plate, then we have a layer of cortex, and then we have a capsule, right? Now, this is important to understand the concepts of hydrodissection and hydrodelineation. So, this is an important clinical nugget for you. So what is the difference between hydrodissection and hydrodelineation? These two are basically steps of the cataract surgery. In hydrodissection, we are basically trying to put fluid, in very simple terms, we're trying to push fluid between the capsule and the cortex in such a way that the cortex will get separated from the capsule and therefore the manipulation of the lens during cataract surgery will become easier. Okay, so if you would know that in cataract surgery, what do? We actually open the capsule, we remove the lens out, and we leave the capsule there, right? So in order to nicely separate the lens from the capsule, we need to separate it using the technique of hydrodissection first. Now sometimes you might want to remove the nucleus first and then go ahead and remove the the cortex. Okay, so in such conditions what we can use is a process of hydrodelineation. In hydrodelineation, we will actually push fluid between the layers of the nucleus. That means we are actually trying to separate the nucleus from the epinucleus. Okay, so if you separate the nucleus from the epinucleus, that is called hydrodelineation, and if you separate the cortex from the capsule, that is called hydrodissection. Then the lens can be actually classified just based on its hardness, and this was actually an old classification, of course, but still it is relevant. Just based on the color of the lens, you can tell how hard the lens is. So if you see a lens which is slightly transparent grayish or maybe very less greenish in color, that is called a grade 1 lens. Okay, if you see a lens turning more into amber color, greenish yellow, that is called a grade 2 lens. If it becomes more yellowish in color, that's called grade 3. If it now starts becoming more brownish, that means the hardness is increasing, and that is called a brown cataract, grade 4, or brunescent. Sometimes the hardness increases so much that the lens will now look black, which is called cataract nigra. Okay, so that is called a grade 5 cataract. However, what we follow now is the lens opacity classification 3. Okay, so what is this LOC classification 3? In LOC classification 3, we are going to basically compare what you are seeing on the slit lamp to this set of pictures, right? So under this LOC 3, system 3, basically we have 6 pictures for the nuclear color and opalescence. So we have this NO1, NC1, you can see it's almost clear. Then NO2, NC2, it has started to get opacified, slightly that whitish color coming up. NO3, NC3, some sort of greenish color coming, NO4, NC4. Here what you see, it is becoming more yellowish, here it has become more yellowish, and then going towards the brownish. Okay, so like that you have 6 images from NO1, NC1 to NO6, NC6. NO means nuclear opalescence and C means color, right? Then you do a retro illumination, and you have basically two diagrams under the retro illumination, right? So for first we'll be actually staging the cortical cataract. Okay, so in that, C1 is almost nothing, you can see on retroillumination. In C2 you can see some amount of opacification has started in the periphery. C3 is that it has started to grow eccentrically. C4 is when it starts to reach the center, so this wedge shaped cortical opacification which has started to reach the center. And C5 is it actually crosses the center, right? Then again, the third set of pictures are for the grading of the posterior subcapsular cataract. So in P1 you have the small speck, P2 is slightly bigger, P3 is more bigger, P4 and then P5, right? So you can actually compare your what you are seeing clinically to this LOX3 pictures. So that's all for today. I hope it was useful. Thank you and have a nice day.